Is bunion surgery painful? Many patients think that this is one of the worst surgeries that you could possibly have or undergo. I've talked to many patients who have had one foot done and they say they're not getting the other one done because of how painful it was, or they've told their neighbor there's no way you should have bunion surgery because it's severely painful. Well, in this video, I'm going to take you through how we perform a minimally invasive bunion procedure. So if you're scheduled to have this done, if you're interested in having it done, this is the video that you want to see. I'm going to walk you through the entire process. So the first thing that we're doing is making a small stab incision on the inside of the foot where the bunion is. And a bunion is nothing more than a dislocated great toe joint. So after we make that stab incision, we introduce a burr. The old procedure used to involve making large incisions over the entire great toe region all the way back into the midfoot. You may have heard of a procedure called a Lapiplasty procedure. That's actually a procedure that's 100 years old that has been reinvented with a new trademark technique with special instrumentation. So that involves a large incision, and what we're doing here today is tiny incisions. We're cutting the bone with this special designed burr that we're using. It's a high torque burr with a low speed, and we're able to cut bone and not disrupt soft tissue. So that's what you can see we're doing here. We're making our cut through that first metatarsal, and then we're going to realign the metatarsal head and put that joint back into place, because a bunion is nothing more than a dislocated joint. So you can see we're pausing here at different times because we're utilizing intraoperative x-ray. It's called fluoroscopy, and that allows us to see the bones we're cutting. So you see, once we've cut that bone, we introduce a hemostat, which is just a small instrument to move the head of the metatarsal over. We're just checking to make sure that we've cut through. We mobilize it with this. And then the next step is going to be to move it over, get it into the position we like, and then we're going to hold it there with 2 screws. So we're just checking here on x-ray, making sure we have our position so that the bone is actually mobile enough. Well, now we're going to take that out and we're going to replace that with a pair of DeBakey forceps. And what these are going to do is provide us with a guide so that we can introduce a wire. Now this wire that we introduce is going to go into the shaft of the first metatarsal. It's going to pass through and enter the head. And we're ensuring that we're doing all of this on our x-ray. So once that wire goes in, sometimes we'll hit our instrument and we know that's a good sign. That means we're in the central portion of the metatarsal. If we do that, like you can see here, we're backing up that forcep or DeBakey a little bit, and then we're going to advance that wire. You can see our toes held back into position. You can see that bunion is already starting to disappear. The next step is to put a second wire in, and this second wire will serve as a second point of fixation for a screw that's going to go in. So this technique is something called a cannulated screw. So it's basically a guide wire that goes in, and then we're going to insert a screw over it so that we're not just haphazardly or blindly throwing a screw. We use these wires for placement. After the wires go in, we measure it. This little device will measure and tell us how long that screw is going to be. And then we'll insert a drill, and we'll drill over that wire. It's going to pass through the first metatarsal and into the metatarsal head. We advance that wire first before drilling, and that just helps to ensure that the wire doesn't pull out when we pull our drill out. Next, we're going to insert that screw over the wire, ensure that it goes into our hole through the skin. We'll take our screwdriver, put it on a slower mode, and we're going to advance that screw into the metatarsal. It'll pass through and grab onto that head. You can see there's some medullary fluid leaking out. That just means that we're engaging into the head, making a nice tight fit to hold that head into place. Once that first screw has been inserted, we'll just carefully check under our x-ray. You can see we're moving back and forth a few times here. We take our hands out of the x-ray so that we're not applying unnecessary radiation to our hands. Make sure we have a nice position for that. And then it's time to put the second screw in. And we're going to do the same thing. We're going to drill over that other K-wire or that guide for the screw. We'll drill through the metatarsal and into the head. Again, confirming on x-ray that we are in a nice position before we make that drill. It's always best to measure or visualize twice and cut or drill once. We'll back that drill bit out. We'll place that second screw onto the wire. And again, it goes flush up against the bone. You can see, if you have a close look at this, these screws are actually beveled on the edge so that when they go in, they're not prominent or proud. They're flush against the angled portion of that metatarsal bone. You can see it there. There's a beveled edge screw that we're engaging our screwdriver into, and it's going to turn in nice and slow into that first metatarsal. You can see we're advancing it here. We want to make sure we're not grabbing onto the skin. Make sure we have passed through into that metatarsal head. And once we have those secured, the wires come out, and the next step is to realign that great toe, because a lot of times with bunion deformities, that toe will get fixed into an abducted position, and that toe starts to deviate away, and the tendon to the great toe will pull, and it's kind of bowstringing it so that the toe is getting pulled over toward the second toe. So when that happens, the next procedure we perform is called an Akron osteotomy. We're making an osteotomy or a bone cut through the great toe bone so that we can re-angle it and make it straight. So now when that tendon contracts, we have a nice straight pull of that great toe. And you can see we're just reducing it. We actually make a cut and we leave a hinge on the opposite side of where we've made that cut. And then we close that hinge down and it straightens the toe. The next step is to use the same technique. We're putting a guide wire through that toe, and it's going to go into the base of the phalanx or the proximal phalanx of that great toe, and it's going to serve as a guide wire. And again, we're checking on x-ray to making sure we have an adequate position. Once that position is correct, the next step will be to insert that screw. Sometimes we have to rethrow that wire. The drill will go over it. You can see we advance that wire through the proximal part of the foot. That's because once we drill, we want to make sure that wire doesn't pull out, because if it does, it's a little bit challenging to get the position of that toe back to where we had it and place that wire back in. We're going to drill over that wire just as we did in the first metatarsal, and this time we're putting a smaller screw in. That first screw that we used was a 3.5 millimeter screw. This one's a 2.5 millimeter screw. We're going to put this one in by hand, and we'll keep advancing it, watching on our x-ray to make sure we are engaging and that that bone cut has been closed down adequately enough so that the toe does look straight. And if you don't have a perfect straight toe with that cut, we can back that screw out and dial it in so that we get it just in the position we want it. And you can see these are small stab incisions. That's it. That's all we were able to do to correct this bunion. We didn't have to make a large incision. We didn't have to dissect and cut through tissue planes. It is 5 tiny incisions. You really only see 3 of them right here. There's a 4th one on the toe, and then there's one on the inside of the toe. Sometimes we don't even stitch those. The suture that we're using here is an absorbable stitch that'll stay in about 7 to 10 days. Sometimes I just leave it in. I don't even need to have it removed, and my patients will be educated on how it works. It pulls out after it starts to break down in the water after they're showering. After about 7 to 10 days, we'll have our patients just put Band-Aids over these areas. So this is much different than those other procedures. They're able to walk day 1 in a walking boot. They don't need crutches. We have them in a walking boot or what's known as a cam walker. They can bear weight. After 3 weeks, that comes off. We advance them to a running shoe. I tell my patients they can do activities such as walking a dog in 4 to 6 weeks, and they can begin impact activities such as running in 4 to 6 weeks. And we'll take x-rays throughout this period. Usually around 6 to 8 weeks is the first set. Then we take a couple sets 2 to 3 months, and then maybe 6 months out, just to make sure everything is in perfect position. If you have any questions about this minimally invasive bunion surgery, drop it in the comments section below.